All right, friends, let's have another session of 51st Comprehensive Course on Echocardiography from Jorop Institute of Echo at Delhi. Today's 11th session of this particular program, and we are going to show you a live demonstration of various valvular lesions and have interactive discussions. This is a unique platform which was developed by Mrs. Rina Dua when we had during the COVID time. We had some time to utilize and we had hardly anything to do. These are the few place icons of Jorop Institute of Echocardiography. This was we are using for a long time. We moved on to this and this particular Jorop Echo Academy India. This is our auditorium where we conduct our state-of-art training programs for the last almost 2007 years. And you are likely to come to this particular auditorium when you come for hands-on training programs. Various legends they are associated with this particular programs are, as you can see, along with the newer one is Dr. Hansa Gupta. She is the Vice President of Indian Academy of Echo as on today. The two persons, Mrs. Rina Dua and Dr. Naran, you have been communicating again and again. And we have many accreditations apart from Indian Academy of Echocardiography, International Society of Cardiovascular Ultrasound, Alabama, Delhi Medical Council. When we do hands-on training programs, we approach them for their recognitions. Similarly, we have to take permission from a appropriate authority of Northwest District or Delhi State Chapter. We are conducting 1 year advanced skill training, 1 year fellowship program with Parul University, Vadodara. And last year, we conducted a training programs for persons appearing in NHS as a technicians. We can say that we started in April 2000, and this is almost 25 years of our establishment. And we are the possible only institute in India, maybe in neighboring countries in the world, which provides hands-on training sessions. And these sessions are being provided by none other than the legends of echocardiography with more than 25 years, more than 10 years of hands-on session experience. Next important thing is we are celebrating a silver jubilee of 25 years of existence on 17th of August in Delhi. And now in this session, which is almost 51st, as you can see that we did the first one in April 2000. And today's session is, we are going to have live demonstrations on valvular lesions. And I'm Dr. Rakesh Gupta, who's going to talk about this particular platform. Initially, I'm going to show you our live demonstrations. And I'm sure you will look at these demonstrations and then we can have interactive question answer sessions. And I'm thankful to Ms. Kansal, who has agreed to be a volunteer for this training program today. She has come all the way from her home to help us out in this particular training programs. With this, let me switch over my presentation to a live demonstrations. And can my screen be smaller in size, Reena? Is that possible? Double click on this. Pause कर देते हैं. So I'll start showing you one by one lesions. And I've got a couple of recordings done already for all of you. Apart from all this.
Sir, screen is visible. Sir, screen is not visible. Excuse me, sir. Only.
Tajinder, all the problems lies with you, nobody else.
Yeah. I can. We started.
All of you, I'm sure, will be able to see the live which is going on. I'm switching over to a particular subject now. Now this is the plaques view. In this plaques view, all of you can see the dome-shaped mitral valve leaflet. This is what is known as doming of AML, hockey stick shape. This is thick. So thickness is, that's how we measure thickness of the valve leaflet. It's 3.43. Truly thickness is about 5 millimeters or more. Then look at the PML. PML is again thickened and it's about 6 millimeters. And if I do my M mode across this thickness, look what exactly happens to AML and PML. This is what AML is. This moves in this direction. The PML also moves in this direction. And why the PML is also moving in this direction is because it's a paradoxical motion of the leaflet. Dr. Ismat, you have to go out and come back again. I can't help you more now. I can't hold it for everybody. And another important part of this particular phenomena is look at this valve leaflets and thickening. And apart from that, what we look is a mitral valve cusp separations. And my cursor this is mitral valve cusp separations. So this is mitral valve cusp separation. It's almost 6.86 millimeters. And then if you draw a line right into the center of this cursor, I'm cutting across my aortic valve leaflets. And now you can see easily my aortic valve leaflet box. So this is my aorta. This is my LA. And this is my AV cusp separations. And the best part of this image is, if your cursor is right into the center, the aorta is right into the center, if you rotate your image to 90 degree, that's what I'm going to rotate 90 degree. Look, my aorta is right into the center now. And when the aorta is right into the center, I've got this pulmonic artery on this side. Pulmonic valve, pulmonic artery, which bifurcates to left and right. This is RVOT. This is aorta. This is tricuspid valve. This is RA. This is large LA. And if you go from here to the papillary muscles, look, I'm bringing down right into the center. From here to papillary muscles, then gradually come back towards mitral valve leaflets. The first structure you see is the mitral valve planimetrized area. And look how beautifully we can look at this. This is AML. This is lateral commission. This is medial commission. This is PML. And we can see in a live fashion. Look, this is how you can do it very easily for a mitral valve area. The crux is go to papillary muscles and gradually come back to mitral valve leaflets. That is the tip of the mitral valve leaflets. I'm coming back. And this is my mitral valve area by planimetry. So I'm going to calculate my area in planimetry by this particular fashion. I can increase my gains, I can zoom it up, and then do a planimetry of this subject. .78 centimeters square. And remember this figure, we'll be doing it again and again. In mitral stenosis, this is the most important part of any mitral stenosis evaluations. Looking at the commissions, lateral, medial, AMO, PML. Look, PML is significantly thickened, some specks of calcification, and this is AML. And then you measure the area, which is again traceable. 1.78 was the earlier one. I'm going to measure it again. Inside to inside, trailing edge to leading edge. And again 1.89, 1.78, 1.89. Almost same, it's not variable. Then next important thing I said, switch on colors in the mitral valve stenosis. Now see how much turbulence you can see in flow across the mitral valve. Now this is red color. This is suggestive of diastolic flow. This is blue color. This is suggestive of regurgitation. So we are focusing on forward flow. And if you look at this forward flow, you see this is hemisphere formation, which is formed in LA side, suggestive of that the severity of the lesion is more in mitral stenosis as compared to mitral regurgitation. For regurgitation, I have to focus on my regurgitation jet, which I'm not going to focus at the present moment. Same patient, if I move my cursor on the aortic valve leaflet, which I'm going to zoom them up, and I can drive the vena contracta. Look, this is what the vena, this is load of the vena contracta, which is seen over here. And I'm zooming it further, switching off colors, bringing on colors, and this is my vena contracta of AR. This is about 2 millimeters. Less than 3 millimeters is considered as mild, more 3 to 6, moderate, more than 7 is severe aortic regurgitations. So in this patient, I'll be focusing more on stenosis rather than anything else. Now the question is, we measure the LA size and now we measure the LV size. And why do we measure the LV size? Because we want to be sure that what we have been dealing with, we are dealing with no any other severe lesion. 41 divided by her body surface area, which is 1.65 meters square. So solar to me about 2.5. So next is short axis view. I showed you how to do it. Now I can see this mitral area very beautifully. Another thing which I want to say is, we talk of thickening. Here is a thickening. We talk of calcification. Look, hardly any calcification is present in this patient. I've reduced the gains completely. We hardly see any specks. The echogenicity of this valve and the echogenicity of the septum and posterior wall, or for chamber of LA, otherwise, there is nothing significant calcium which is seen on this valve. Then subvalvular operators. Now focusing on subvalvular operators. Now, what is subvalvular operators is? We look at this cords. Look, there are hardly any cords seen over here which is thickened. So thickness, mobility, calcium, subvalvular operators. There are 4 things which talks about mitral valve Wilkinson score. As for the aortic valve score is concerned, it is significantly thickened. Again, 4 millimeters, but it's again doing in systole. That was doing in diastole, now it's doing in systole. It means she has some amount of aortic stenosis also. That is what's seen by 2 dimensions echo. And now we can see a turbulence across the aortic valve with systole and regurgitation flow with diastole. We showed that in one of the parameters that she has got a mild aortic regurgitation. So I'm moving on from this. I want to see my LV function and other things. So at this present moment for MS is, the cusp separation is almost 7 millimeters. LA is dilated. Leaflets are thickened. No calcium. Mobility, if you scale of 0 to 4, will be about good mobility. Then no calcium, no subvalvular apparatus involvements. So from here, I'll just look at my mitral valve, tricuspid valve. Pulmonic valve, and I want to see what is the pulmonic flow velocity, because then I'll not be coming back over here. My pulmonic flow velocity is almost 1.01 meters, hence nothing significant as far as pulmonic velocity is concerned. From there, I'll try to move on apical window. I'll be focusing first on LV size and functions. I showed you LV, that was normal. I've increased again deliberately. Now you can see my LV, 4 chamber. This is septum, this is lateral wall. Very good contracting septum and lateral wall. Then I rotate 90 degree to get my true anterior inferior wall. This is my true interior wall. This is inferior wall which has got a papillary muscles and a good contracting LV. Now rotate counterclockwise further. My anterior septum and posterior wall. This is my anterior septum. This is my posterior wall. Posterior wall does not have any papillary muscles. When it shows intermittently the papillary muscle comes, it means that becomes inferior wall as far as evaluation is concerned. So this is how we talk about wall motion abnormalities, which is almost normal, and we have a dedicated module on a wall thickening abnormality. Now going back to my mitral valve, now I have to adjust my images in such a fashion that I'm able to see my LA, reduce my gain in the superior surface of LA. Now this is optimized image for mitral valve. And now I'm going to switch on my colors. Now you can see a beautiful flame-like structures originating from mitral valve and going to from LA to LV. You cannot see a better flame-like structures on this. You have some amount of mitral regurgitation in the same subject. And if you take that criteria of jet area versus LA area, it will be almost 25 to 30% mushkils. So this is what my flame area is. Now I'm doing my pulse wave Doppler spectrum at the mitral valve levels. So what I'm seeing, I move my baseline down. Increase my scale as much as possible. Not more than 4 to 5 complex in every beat. And now what exactly happening? We are seeing some complexes. I request everybody to silence your mics. Did I check the problem? Now look at carefully. We have some complexes where my E wave is very big. Other complexes E wave is smaller, 1.85 and 2:4. Which one we should take? The answer is when the patient is inspiring, when the patient will inspire, what will happen? The right sided flow will increase and the left side flow will fall. So we are not going to take this particular second or fourth sample. Same time, I'm going to back and go back record again. And I'll show you what exactly is happening. Now this is my respiratogram. When she will inspire, the respiratogram will show up scales. When she expires, it will go down. Good. No. Now this is expiratory phase. As soon as she started inspiring, her L function went down, the velocity went down. So we have to be in end expiration for recording your Doppler flow pattern across the mitral valve. In fact, for any condition, we have to be in expiration or before inspiration. So I'm going to do it again. Second thing which I wanted to show is that I'm able to contain this Doppler spectrum pattern with a pulse wave. If you can't contain this Doppler spectrum pattern with pulse wave, what you should do is you should switch over to continuous wave Doppler spectrum. ऐसी बहुत ज्यादा होती है तब से मेरे सपना All right. So what I've done is I've used pulse wave and I'm able to contain the Doppler spectrum pattern. What do you mean by containing the Doppler spectrum? My E wave is seen, but A wave is not seen. So if my E wave is not seen, I'll go back and go to continuous wave Doppler spectrum pattern. Okay, now I'm going to reduce the gains. Now trace this Doppler spectrum pattern. Starting from the baseline, go up, go to the peak, come back, end of a T wave, beginning of A wave, and coming down all the way for end of a T wave, and then take a heart rate. Now you can see 2.68, 1.91, 29, and 16 is the gradients across the subjects. Now we can look at the pressure half time of the same patient. So we'll go to pressure half time and then give you area. This is 1.18, again 1.36, 1.25. Variability would always be there. So that's how we look at pressure half time, area, and other things. Let me just switch off this respirator fan. Beautiful. This is the best I could derive because earlier one I was not very comfortable. Now this is very clearly seen. You can see a peak of E wave, peak of T wave, E and A waves. I think I'll be getting a better answer with this rather than the previous one. So what we see is a mean gradient of 9 millimeters of mercury, and which again correspond to moderate mitral stenosis. Pressure half time shows 0.89, 0.82, which is I'm not really sure what exactly it means by, but I'll let you know why it's happening. Next is we look for TRZ gradients, because in new guidelines the TRZ gradient is very significant. Earlier it was 30. Now severe MS talks about 60 millimeters of a TRZ gradient. So let's look at the TRZ gradients, and I could see intermittently the TRZ gradients. So here is my TRZ gradients. I could see a tip of the tongue, 2.23 and 20 millimeters of mercury as a gradient. It's not 60, again, not suggestive of severe MS. Again, the next one I would like to show LVOT first. This is LVOT, just before the aortic valve opening, away from a turbulence, and this is what we are getting in LVOT flow. And my machine automatically tells you my LVOT VTI, which is 28.26. Anything more than 24 is considered as normal. This is also a marker for systolic function. Now, we switch over to now continuous wave Doppler because we were thinking of thick mitral valve leaflets. I'm moving from my LVOT towards mitral valve. Now you can see an aliasing which is happening. I'll go right into the aortic valve leaflets. Now I'm going to increase my scale to the maximum one, wave pulse wave, move my baseline up, but still I'm not able to contain my Doppler spectrum pattern. Switch over to continuous wave Doppler spectrum pattern. Oh, you can see what is the velocity. I'm adjusting my gains, and I don't have to be in inspiratory phase. I'm going to be in expiratory phase only. This is 2.75. This is inspiratory phase, 2.83. But actual this is where it is. So I'm not going to talk about aortic stenosis. I'll try to show you aortic stenosis in a few minutes' time. So let me comprehend myself. अब बैठना चाहोगे तो बैठ जाओ बस में चाय मंगवा दूं तो कुछ है हमारे पास सब कुछ अपस्टेयर्स है चाय उस बॉक्स में देखो कि लॉजेंसेस पड़ी है पानी गर्म पानी दी ठंडा पानी so at this point let me just discuss about mitral stenosis. So what we need to look at mitral stenosis, I showed you the mitral valve plus separations, thickening, calcification, mobility, and subvalvular apparatus. Then second important thing is mitral area by pressure of planimetry. Third important thing is peak and mean gradients. Mean is more important. And the fourth important thing is a TR-jet gradients. Based on this, what we come across, we always come across the severity of mitral stenosis. If you take up this subject one by one, let me look at the subject one by one. This is the best image I could get, which I was able to show subsequently. First image, I was not very happy. This is 9 millimeters of a gradient, which clearly think between 6 to 12 is moderate. Then third is a TR-jet gradient, less than 60 millimeters, non-severe. Then cusp separation is about 6 millimeter to 7 millimeter, again moderate. LA is dilated. There's a thickening of leaflets is present. There's no calcification. There's no subvalvular apparatus thickening. The mobility is good. And the last one, what we saw a mitral area by planimetry of 1.7 to 1.8 centimeters square, again consisting of the criteria of moderate mitral stenosis. Three important things which we need to look at this mitral stenosis patient when we do a balloon valvotomies. One important thing is what is the severity of MR? In this patient, severity of MR was almost mild. In this case, I'm not evaluated, but does not look to be significant. Any LA appendage thrombus, which is not there, any thrombus in LA or LA appendage, which is contradictory for balloon valvotomy. MR, LA thrombus, LA appendage thrombus, and the next important thing is commissural calcification. If you look at this subject, there is hardly any commissural calcification. Just reduce your gaze. Look, this is only the specks of calcium which is seen over here. Correct? There's hardly any calcium in this particular valves. So what I've done, I've zoomed down the 2D gains completely. So this patient, if she classifies, she does not at present, if she classifies into severe mitral stenosis, when the area is less than 1.5, gradient is more than 12, and the most important thing is we have a mean gradient of more than 12 and peak more than 60 millimeters of mercury. Then we talk of doing a balloon valvotomy. And 4 factors will consist, and we add 4 from a drop, talking of commercial calcification, LA thrombus, LA appendage thrombus, and presence of at least moderate or more mitral regurgitations. Questions. Now you can raise your hand one by one so that I'll answer your question for mitral stenosis. Then quickly switch over to mitral aortic stenosis, because then I'll make a free from it. Questions for aortic mitral stenosis. Can you raise your hand? All right. Question, Qasim Ali. Quickly, Qasim, we don't have much time. Just ask the question.
Good evening, sir.
No, good evening, good morning.
Sir,
Just question.
which structure included in the subvalvular apparatus, sir? Please, sir, clear me, sir.
The leaflet, below the leaflets is papillary muscles and the cords.
Yes, sir. Papillary muscle and yes, sir.
Cords.
Oh, yes, sir. Yes, sir. Yes.
Anybody else? All right. Kamal Kishore to everyone. Go ahead, Kamal. Kamal, some questions you have? No. Dr. Veena?
Sir, how to calculate these findings in AF?
AF, you have to record these findings at least 5 to 7 times
Yes.
and then take their average. Just give me a second. I'll show you a patient from AF.
Okay, sir.
So my mic was mute that time.
Pardon?
My mic was mute that time by mistake.
Okay, no problems. It's for your benefit, man. It's not for my benefit. Now, can you see the screen?
Yes, sir.
So these are all various complexes of atrial fibrillation. Look, this is the longest deceleration slope. This is further longer. This is smarter. This is slower. So what we'll do, we'll take the longest scope. Okay, machine has done its job automatically. So what we do is, wait a minute, machine will record it. So I'll say approve without image storage. Okay. Now machine, what is given is first complex is top of 2.13, 1.41, 9.14. Then this is what the gradients are. Second complex is 1.88, mean gradient of 5.13. So I'll use this gradient, this one as a good sample volumes. I'll not use this. I'll get rid of this particular sample one over here. So what I'm going to do is, I'm going to go, now I'm going to show you what exactly I'm going to do in this patient is. In this patient, this is no A wave is seen. First of all, whenever you see A wave, you understand that the severity of MS is not there. Second, this is first wave. Look at the gradients 8.5, 8.25. Then second complex, I'm taking it. Look at the gradient 6.34. And then I can go and look at the pressure half times. First pressure half time, second pressure half time. So 0.84, 0.86, it will be variable. But in this patient, the most important thing would be gradient. When you take a gradient of 8.25, 6.34, then you take 5 or 11 of these complexes. Average them up, what is your mean peak and mean gradients are. Then similarly, these people we have gone to do mitral area by multiple times by planimetry. Look, this is 3-dimension echo. If you look carefully, my cursor is cutting at the tip of the mitral leaflets. And this is what I'm getting the mitral area. There is absolutely no doubt I'm at the tip of the mitral leaflets. But without that also, I've done it. Look, I've done the same thing out here. So this is mitral valve area is. In atrial fibrillation, look at the mean gradient by average values and look for a mitral valve area by planimetry. Planimetry area is more important in mitral stenosis than anything else. I hope that solved the questions.
Okay, sir. Thank you.
Dr. Madhav Bansal, can you lower your hand also? Quick, Madhav.
Sir, yes, sir. Sir, when we measure the mitral valve area by planimetry, sometimes it is difficult to figure out when to stop rotating or tilting the probe. Where exactly?
No, I showed you very categorically. Go to Plaque's view. From Plaque's view, gradually come back towards mitral valve. And as soon as you start seeing the mitral valve, that is the tip of the mitral valve leaflets.
Okay, so sometimes the entire border is not seen.
That's what I showed in the beginning. That's what exactly I showed you in the beginning is, I showed in the subject, you should start doing an echocardiography from this point. Look, I showed you the first point is, you did not hear me correctly. I said, you put your cursor right into the center of the mitral leaflets, aortic valve leaflets. Look, if I draw my line, if I draw my cursor, this is my cursor is right at the center of the leaflets. So aortic valve should come into the center. When the aortic valve will come into the center, your mitral valve will always come into the center. Okay?
Okay, okay, sir.
Dr. Qasim Ali, quickly.
Sir, last question, sir. One option of machine has, sir, one option of auto trace. Sir, it is authentic, sir, auto trace. Sir, in
डॉक्टर
mitral area.
डॉक्टर कासिम अली कुछ कुछ काम खुद भी कर लिया करो भाई,
Yes, sir, sir.
ठीक है ना? मतलब सारा कुछ ऑटो ट्रेस कर दोगे तो कल मशीन भी आप पेशेंट भी आपको ऑटो ट्रेस कर देगा। हाथ नीचे कर लो, क्वेश्चन पूछो, जो मशीन के चक्कर में पड़ोगे तो गड़बड़ हो जाएगी।
Yes, sir. Yes.
Okay, let me go and quickly show you the aortic stenosis now. देखो, नमक कम कर दो, नमक ज्यादा खा लिया, वायरल फीवर हो गया। अच्छा, एसी बंद कर दो, चलेगा। Now the same patient, I'll be focusing on aortic stenosis. The most important point for aortic stenosis is looking at the LVOT diameter. Look, I'm focusing on LVOT diameter. Perfect. So my question would be, look at the point where you see the opening of, it's not visible. Again, on images, and it's a practice which will make it perfect, doing it again and again. If you ask me, the toughest part in doing aortic stenosis is my aortic valve opening, now cusp opening or LVOT diameter. Now look, where is my cursor is an ECG gating, mid-systole. This is the hinge point of right coronary cusp. This is a hinge point of non-coronary cusp. So both the leaflets are equally seen if you look at carefully. And if I have to develop an LVOT diameter, this is my LVOT diameter is 1.6 centimeter square, 1.6 centimeters. And I have to do this again and again in aortic stenosis. Look, I'll be doing it again and again. We have that. If you develop a perfection in this, your work is done. And this has to be mid-systole. One hinge point, second hinge point, 1.5 again. And both the leaflets should open up. Now look, both the leaflets are equal and they'll open up. They're not equal. Now they're equal and they're open up. Hinge point of a right coronary cusp and non-coronary cusp. All efforts 1.5, 1.15, 1.55, 1.59, 1.57. And I've done it 3 times now. I'll do it 2 more. Almost same. .54, so I can assume my LVOT diameter is 1.55 centimeters. Is that correct? Now the next question comes, whether this patient has got LVH or not. For LVH, the criteria is, now I'll repeat the same thing somebody is asking was. I'm at papillary muscles. Now I'll go gradually back towards mitral valve or aorta. Let's say aorta. So if I'm going back towards aorta, in between the mitral valve will come. So from papillary muscles, I'm going towards aorta. So in between, you'll find the papillary muscles. So as soon as I see my papillary muscles or mitral valve leaflet tips, now leaflet tips are seen. It means I'm at the tip of my mitral valve leaflets. There is no second thought. Do it as many times as possible. Furthermore, it will be aortic valve. And if you look at aortic valve carefully, before you go to aortic valve, this is her LA appendage. So sequence is papillary muscles, then mitral valve, then LA appendage, and finally the aorta. So you can look at all these things in one go. Look, LV appendage, aorta. In LVH, what you're going to do is go to papillomastosis level, do an M mode. If she's carrying a significant LVH, it will be seen over here. So I'm doing the same thing which you do, all of us does. My RWT is less than 42. This is less than 42, RWT 0.42. In females, this has to be less than 95, which is almost same. So if this mass is less than 95, is RWT is less than 42, we have normal LV geometry. If this mass is more than 95 in female and 115 in males, more than 0.42 in any subject, then we call them as concentric LVH. So if you have aortic stenosis, some severe aortic stenosis, we have to have a concentric LVH. Although this is not a dictum, I can show you a subject where the patient was carrying a severe aortic stenosis, but no LVH. Same patient, I showed you LVOT. I'm going to show it again. So we have this LVOT. Now, if you look at this carefully, we have an AR jet. So I'll not keep my cursor into AR jet. I'll be away from this AR jet and away from a turbulence of aortic valve. So I'll be keeping my cursor over here most probably. So I'm keeping, this is a turbulence which is seen over here. So I'll be keeping my cursor away from a turbulence. And let the machine is doing by itself is good. 27, last time it was 26. 27 centimeter is my LVOT VTI. So this is 27 centimeters. Second is what we need in this patient is a CW to look at a continuous wave velocity gradients. Fine. I'm going to trace them up now. Although I'm doing it, I'm not very happy, to tell you very honestly. So this is peak velocity is 2.89, mean is 2.03, peak gradient 33, mean gradient 18 millimeters of mercury. Doppler velocity integral is 0.45, which has to be less than 0.25 to talk of severe aortic stenosis. Why I'm not happy? I'll show you in a couple of seconds. And this is what the machine has done automatically. I did not do it. What I'll be doing it, I'll reduce my scales. And I'll get a much better Doppler spectrum pattern when I'm doing it manually, not by like Dr. Qasim Ali. Qasim Ali says everything to be done by machine. No, not that way. I don't depend on this machine to a large extent. Now look at the Doppler spectrum pattern. I'm getting a much better Doppler spectrum pattern. I'm happy with this. Next point is acceleration time. So this point to peak of this is acceleration time. This point to, I'm again measuring it again. I'm sorry for that line went down a little bit. So this is acceleration time. This is ejection time. So the peak velocity is 2.69, mean is 2.01, peak gradient 30, mean gradient 17, DVI 0.41 now. And based on this, we can say that we are not belonging to severe aortic stenosis. And if I measure my LVOT, it will give me aortic valve area automatically. Let me just do that LVOT measurements. No, they have removed it anyway. So, and next important thing is, as we did in 5-chamber view, we must do in 3-chamber view. Let's look at how much is my gradient in 3-chamber view. 2.54. So 5-chamber view was better than this. Same thing we'll do in subcostal, right parasternal and suprasternal. And another important thing is the LV function of the patient. This function looks to be reasonably normal. You can raise your hands for asking question for aortic stenosis. I'm doing something which is not of your level. I'm doing a GLS for this subject. Beautiful recording. Now automatically giving the ejection fraction of 60%. Here I'm dependent on this ejection fraction by this GLS because imaging quality has been so good that my ejection fraction is perfectly well. And this global longitudinal strain is 17, which is not reduced. In case this is reduced, it means my LV function is getting down. So that's why I look at my GLS. So I'll approve and come out of this particular aortic stenosis. Let me show you the gradients. So let's comprise thickening of the aortic valve leaflets. Along with it, doming in systole, LVOT diameter, LVOT VTI, aortic valve VTI, and based on this, we are able to calculate the aortic valve area. This patient has got a gradient less than that, less than 4 meters of a peak velocity, less than 40 millimeters of a gradient. LV function is normal. And based on aortic valve area, we have to calculate whatever is the blood flowing through LVOT has to flow through aortic valve. So LVOT diameter, somebody can take out a calculator. I'll just name somebody who has to take out a calculator. Dr. Abhijit More. Open your mic.
Yes, sir.
Calculate 1.75 divided by 2.
0.875.
0.875 multiplied by 0.875. That is a radius square. Multiply it.
0.7.
0.7 multiplied by pi. Pi is 3.14. Multiplied by 3.14.
2.4.
2.4 multiplied by LVOT VTI. 27.56.
66.3.
Correct. Now 66.3 is her stroke volume per beat. If you divide this stroke volume by body surface area, what is that area is? 1.65. 1.65 is the body surface area. Divide this volume 66 by 1.65. So what is the value?
40.2.
40.2. So we have index stroke volume of more than 35 ml. It means even if it's a stenosis, that's a volume which says is high flow volume, high flow in the volumes. Now 66 divided by aortic valve VTI. What was aortic valve VTI? I'll just show you aortic valve VTI. Aortic valve VTI is 64.91. You know,
1.2.
So we are more than 1 centimeter square for a aortic valve area. Are we clear now?
Yes, sir.
Okay, you can switch off your mic. Your kids are making noise from the behind. They're enjoying your class. Daddy bhi padh rahe hain aajkal. So let's, Dr. Muzaffar, go ahead and ask your question.
Good evening, sir.
Good evening.
Sir, how do you do this M-mode in aortic stenosis and what is significance?
M-mode aortic stenosis is like I showed you that picture. Let me get that picture again. Now I'll show you that picture. Just wait a minute. The significance of M-mode in aortic valve is I'm now focusing on M-mode and aortic valve, right?
Okay.
So I'm in the center of this cursor, taking an M-mode. Great. So I could see at least one good complex. This is the one good complex which you see over here, correct? So
Yes, sir.
in aortic stenosis, what will happen? The opening will get restricted. So my aortic valve opening is 14 millimeters. Normal opening is 15 to 26 millimeters. So it's getting restricted. And most important thing is if you compare the opening, look at the aortic valve opening. This is the opening which is restricted. Look, if you look at carefully, the valves are not opening perfectly. This valve is not opening perfectly. So these valves should stuck over here, this valve should stuck over here, and the annulus and this alveoli area at the annulus should be the same almost. Maybe the sinus of Valsalva's flow would be more because they'll be sticking almost to sinuses. So M mode is when you see an M mode, I'm not going to do it again for you. Cutting across the M mode of the aortic valve leaflets. Now again see, this is maximum I'm going to get is 13, 14. So it's minimally reduced. If it's less than 15, then we definitely say that M mode shows reduced excursion of the mitral valve, aortic valve opening. All right.
Okay, sir.
Next is Dr. Madhav Bansal. Ask your question and lower your hand.
Sir, please tell me again about LVH. How you quantify? How you see whether LVH is there or not?
LVH, I showed you. I went to parasternal short axis view at aorta at the papillary muscle levels. Look, this is where I went to papillary muscles level. I went to this papillary muscles level over here, and I did an M mode across this.
Okay, sir.
Correct? When I did an M mode across it, what I measured? I measured the same dimensions. This is interventricular septum during diastole, posterior wall during diastole, interventricular septum during systole, and this is the posterior wall during systole.
Okay, sir. Then
The machine will give you, look, this machine is giving you two important values, RWT and LV mass in diastole.
yes, sir.
Correct?
What is the RW stand for? RWT.
Regional wall thickness.
Okay.
This is calculated by, there's a formula to calculate this. Machine already gives you. If I'm correct, the formula is LV dimension during diastole divided by 2 and then divided by LV IDD. I don't remember it correctly, but there's a formula. Machine is fed with this formula.
Okay. LV
This is how-
dimension means LV. Okay.
LV dimension during diastole. This is LV dimension during diastole.
Okay, sir.
So this is a formula which calculates this LVH, and we'll show you again this particular phenomena. And otherwise, number of countries, what they are doing is they are just looking at this particular things, you know. So suppose this is a diastolic frame. This is not a systolic frame. So what they are doing is they are measuring the basal septum more than 12. So this is 10. They are measuring the mid septum. 9. They are measuring the posterior wall. 10. They are measuring the mid posterior wall. So if these walls are more than 12 millimeters all around, then we call them as concentric LVH. But this is what is recommended by American Society of Echo to talk of concentric LV geometry. Does not look to be still convinced with this.
Yes,
Just
sir. There
note
was
down
a
this.
voice interruption actually.
Note down this point. I'll demonstrate this point during question answer sessions later on. Okay.
Okay. Okay, sir.
Let's move to next. Just switch off your video. Next question is Dr. Mal.
Yes, sir. So actually, continuing on the same question, same thing, but you said you'll explain this during demonstration. So either of the two have to be present, or both of them have to satisfy the
No, we are looking at concentric LV geometry in this present scenario today. British Society of Echo talks about LV wall thickness. So much variability is there. Just write down this question. I'll give you a detailed answer for this.
No, I mean to say, sir, LV mass and RWT, do we have to take both into consideration? Or
Yes.
either of them is
No,
fine?
no, both into the consideration.
And if only one is present,
Then either concentric remodeling or eccentric hypertrophy.
okay, we'll deal with this later, sir, I believe.
Yeah, we'll deal this with it.
Okay, thank you.
Dr. Shamina Sultan.
Assalamu alaikum, sir.
Walaikum salam.
Sir, how can we measure high flow or low flow from the measurement?
We will talk about all this, Shamina. You can write down this question during question answer. Right now, I showed you how to look for a flow by stroke volume. Is that correct?
Yes, sir, but I can't understand, sir.
Why did you understand? What is what is the shortcoming of not understanding is?
Sir, we can measure LV OT area or OT valve area, but how can we measure a flow, high flow or low flow?
Okay. High flow, low flow is when we do a stroke volume, if I've taken my LVOT diameter divided by 2 is a radius, square of a radius multiplied by pi, that is 3.14 into LVOT VTI, they'll give me stroke volume. Is that clear?
Yes, sir.
Stroke
Yes,
volume
sir. Clear.
divided by body surface area will give me index stroke volume.
Okay, sir.
If my index stroke volume is more than 35 ml, then is high flow. If the index stroke volume is less than 35 ml, this is slow flow.
Okay, sir. Okay, sir. Now clear.
High gradient means my peak velocity is more than 4. My mean gradient is more than 40. Then is high gradients. If my peak velocity is less than 4, my mean gradient is less than 40, then is low flow. Then the question is, we have 4 variety: high flow, high gradient, high flow, low gradient, low flow, low gradient, low flow, low gradient with poor early systolic function. Right at this point, I'll show you with the slides. Okay?
Okay, sir. Now I'm clear, sir. Thank you, sir.
Thank you. Anybody else? No more questions? Qasim, quick. No good evening, good morning.
One question, sir. We have any significance of LVET, sir? One option in echo machine, sir, LVET, left ventricular ejection time. It is, sir, significant to
Left ventricular ejection time, I have to read. In this ejection time, left ventricular ejection time is, I don't know, in which context is asking, you're telling. Which machine, which era's machine is there? 1900, 1908. Year of the machine is 1918.
Sir, I will, sir, next time I will show you, sir, iske picture of that, sir. Yes, sir.
This machine is of 1918 era.
Yes, sir, Samsung machine, sir. I have no idea, sir.
Okay, no issue. We will talk later on. We're not going to take anybody's company's name in this, okay?
Yes, sir.
So are we clear with the aortic stenosis and mitral stenosis? I just want to show you one more live demonstration, then I'll make her free because she must be tired by now. She's almost 1.5 hours over here. So in mitral regurgitations, next is first important thing is aortic regurgitations. Let me focus on aortic regurgitations now. All right. So if you look at this jet, this looks reasonable. All of us understand the curved loading also. Transloading. So what I've done is I have gone through that AR. Now I'm fixing AR now one by one. Now we have LVOT diameter already with us. What was that LVOT diameter? 1.75. Correct? So three important points are needed in aortic regurgitation. One is a vena contracta. Now look at the vena contracta at the origin of the jet. Look at this pointer over here in QRS complex. So this is beginning of systole. So we'll see AR jet in systole or diastole. We have to see a jet in diastole. So we'll go to the diastole. Now I'm zooming it up. And this is what my vena contracta is. I have to be sure where my vena contracta is. I'm switching your colors. So this is my vena contracta right over here, in between the two leaflet tips. Almost 2 millimeters of a vena contracta. 1 point. Then, what is a jet width height at the level of LVOT? This was LVOT. So this is jet width height oblique LVOT. So my LVOT was 1.75. My jet width height is only 2.27, which constitute to almost how much? About 15 to 20%. Look very carefully. The point where my jet is originating, the point where I'm measuring my LVOT diameter. Not diameter, LVOT jet width, not LVOT, jet width height. So this is a point where I'm measuring my, I'm sorry. This is a point where I'm measuring the origin of the jet is now again. This is a point where I'm measuring the origin of the jet. This is between two leaflets of the aortic valve leaflet. Look, I'm switching on colors now. Look at the jet. So let me try to make it two different windows. One with a color, one without a color. This is what vena contracta is. Second important issue is I have to measure my jet width height. So jet width height would be the longest portion at the level of LVOT. This is my LVOT and this is my jet width height. That was almost 5 millimeters, 4.5 or 5 millimeters. And that was again 1.75 and again constitute to be less than 30%. Mind my words, when we measure my jet width, when do you measure my LVOT height? LVOT height would always be measured during when? Systole, not in diastole. Height would be in LVOT height in systole, that was 1.75. This is not an accurate measurement. So that was 1.75. This is hardly 0.45. So we have vena contracta, jet with height oblique LVOT height. Third is LV size, which was normal in this patient. And the fourth important subject is a pressure half time. Now I'm going to show, I'm not concentrating on aortic forward flow. Now I'm concentrating on pressure half time. Now I'll ask the machine to do auto. No, machine is not happy with me, nor am I. Yes. Now you can see this. So this is what pressure half time of aortic valve is. This is the pressure half time. How much it is? 729. More than 500. Myac. Correct? Next important part of this particular phenomena is what we look is what is the amount of flow which is happening in descending aorta. मैं तेरा सारा एको कर लिया बहुत ज्यादा डिटेल होगी टचवुड बिल्कुल नॉर्मल है थैंक यू तो मेरे को बोलना चाहिए तेरा so I'm in descending aorta now. So my pulse wave is in descending aorta. So I have hardly any reversal of flow. This is my reversal of flow. I'm going to trace it. I'm just encroaching on my line, but it's not correct. So VTI is only 7.5 and the end diastolic velocity is only 10 millimeters. More than 22, more than 22. 22 millimeters of VTI, 22 millimeters of end diastolic velocity. That's one point. Now let's look at the very important point is whether the regurgitation jet is there in polar diastolic or not. So what we do is we put a line, do an M mode. You can see hardly any regurgitations. Look, there's no regurgitation seen over here. This is systolic. Downflow, there's hardly any regurgitation over here. So this is suggestive of, again, mild aortic regurgitation. I am going to make a free, then take your questions. One more point I want to show in MR is, amongst all the features of MR is, look, anybody will say this MR is mild, moderate, severe. Now I'm going to make it as maximum as possible. Now, you have variability of opinion, at least mild to moderate. But the most important thing of any significant MR is go take a pulse wave right into the pulmonic veins. Good. So if you look at carefully, what exactly is happening? In pulmonic flow, this is systolic pulmonic flow. This is diastolic pulmonic flow. Watch it, the systolic flow is more than diastolic flow, or almost same. I'll do it again. It is a little bit shorter down. And one more thing which I did not do and nobody pointed it out to me do it. So I have to reduce my scale Nyquist limit to 40. As soon as I reduce my Nyquist limit to 40, what happens? I'm able to see a very good flow. Okay. Now this is systolic forward flow. This is diastolic forward flow. In case of a severe MR, this will reduce in size. What will happen? Systolic flow will become lesser than diastolic flow. It becomes truncated. It means it will be over here only. Diastolic will be more. And in severe MR, this will get reversal of flow, which is not there. Last point. I'm trying to show you a vena contracta for MR. Maybe I'm able to show because the lesion is not severe in our case. I'll not be able to show a very good vena contracta, but I'm trying to show a live vena contracta. No, I'm not able. I'll show my recordings, but I can show you a very good pizza for mitral stenosis. Look, this is a very good pizza for mitral stenosis. This is what the pizza I'm talking about. Very good pizza. And this tells you that mitral stenosis lesion is more dominant as compared to mitral regurgitation. Any questions before I make a free? You can raise your hand one by one. Then I'll go to my recordings to answer your question and I'll show you one case of MR also. Dr. Mal, go ahead.
I didn't quite get the last point, sir, that MS is more severe than MR. Can you please reiterate?
This is what you can see a vena contract. This is when you see a pizza, proximal isovolumic surface area. You can see multiple colors, ring-like structures. When you have MS with MR, the side you see a pizza, that is the more dominant lesion is.
Okay, sir. Okay.
This case, the MS-MR, she has got both MS and MR, but we are not see significant MR. If I see MR also more than this, what will happen? If MR is severe, this pizza would be formed on LV side.
Okay. Okay. Got it. Thank you.
Okay. Dr. Sharmina Sultan.
Sir, how can we measure PISA?
No, we are not going to talk about pizza. Sharmina, you have to come to Delhi in August. We are doing an advanced skill training in eco-application technology. Spend some time, money, and energy. Visit us in August.
Okay, sir.
Sir, so this holds good in either of the phases, like both in systole and diastole?
Yeah, if MR is there, it will form in systole. If MS is there, it will form in diastole.
Okay. Yes. Yes. Okay.
Dr. Chandrakanta Patil.
Yes, sir. I want clarification that jet width should be calculated at LVOT area and
LVOT
when a
site.
contract, sorry, sir, and when a contract at leaflet area, sir, leaflet.
And that in between the leaflets.
Yes, sir. Yes.
Dr.
Okay.
Patil, if you go to villages, we
Yes.
used to have two door used to have two parts of a door.
Yes, sir.
Over a period of time, those two parts of the door they get used to be molded in a different form. So there was some potential space used to happen in between after a long time. In villages, very common.
Yes, sir. Yes.
And through that particular place, the wind used to blow back into the house.
Okay.
Correct?
Yes, sir.
अगर आपको याद है पुराने जमाने में वो कहते थे यार दरवाजा बंद कर दे यार दरवाजा टेढ़ा हो गया.
Yes, sir. Yes, sir.
तो टेढ़ा होने पे जहां से हवा निकलती है दो पल्लों के बीच में, that is what the vena contracta is.
Okay, sir.
Whether it's aortic or mitral.
Okay.
And jet width height is at the level of annulus, LVOT diameter.
Okay, sir. Okay.
All right.
Okay, sir.
Anybody else? Any other questions? Then let me show you one or two quick cases and then we call it a day. I want to show you a good vena contracta first for MR. मैंने एक पेपर टंगा वहां पे देना लोग को जरा प्लीज. Now this is another patient. Now you can see very good vena contracta. Can you see the vena contracta? सामने पेपर है मुझे और नीचे पास में पेपर है बस. Thank you, Sapna. So this is what vena contracta is, just between the two leaflet, and this is the jet with heights. सबसे नीचे का नाम यही वाला. All right. नीचे right. Right, last one. Now look at this patient. This is eccentric MR jet. And if you look at this eccentric MR jet, if we have done a pulmonic venous flow pattern, so echo 02, LVOT diameter, MR severity, 1000. Class. Question. Okay, thank you. Bence burası hiç çok yaygın. Hatırlı çok yaygın. So any other questions? All right. This is what I was trying to show you. Now this is a patient of, look at the colors, this is MS with MR. And as soon as I switch on my color, what I'm going to get is both forward flow and the reverse flow. And the reverse flow, what I'm getting is MR. I'm switching of colors. So this is what the vena contract through these two leaflets, the MR jet is happening. When I'm switching on the colors, look at my Nyquist images, 66. It should be a little lower. This is on the higher side. It should be a 50 to 60. And this is what the leaflet is through which is MR is happening. About 0.6 centimeters, 0.5 or 0.6 centimeters. This is how we look for MR jet. So MR, and second thing in MR jet is, what we look is how much is the MR jet in relation to LA area. So that's what we do in this particular fashion. So first I'm going to calculate LA size, measure area. So I'm going to calculate my LA size. This is 48 centimeters. Then I'm going to trace the maternal regurgitation jet. These are old things which used to happen long back. So this is how we measure the jet area. So jet area versus LA area, vena contracta, LV size, and then reversal of flow in pulmonic veins will give you a severity of MR. Next, one more important thing which I'd like to show is TR. How to look for tricuspid regurgitation severity. Now all of you can see a TR. So I'm going to freeze this TR during when it's equal to maximum vena contracta. Now this is a maximum vena contracta, and then you measure this TR as 11 millimeter. So it's more than severe, less than massive. But this TR will not going to change your clarity for PA pressures. This is just tell you that is severe because the ring dilatation depends on surgical evaluations. And one more thing, what we do in this subject is nowadays we are looking at this tricuspid valve. Somebody was asking, this is what we are going to do during advanced field trainings. Now, in this tricuspid valve, look, I've got all three leaflets of the tricuspid valve leaflets. This is my septal. This is my septal leaflet. This is my AML, anterior tricuspid valve leaflet. This is posterior tricuspid leaflet. Now look at again carefully. Not at your level. I'm not saying that this is your level. This is what we look when we talk of a TR jet evaluations. And when we talk of a TR jet evaluation, for surgical point of view, this is how we look for a classical tricuspid regurgitation area. This is again 3 dimensions area. Now I'm going to freeze this image for you. Going to scroll it gradually to get my. So this is my tricuspid regurgitation area. So this is my area of the tricuspid regurgitation depth. This is more important than vena contracta for doing like annuloplasty and other things in cases of secondary TR where this reason has come because of a left-sided reasons. And answer for this is one, we showed severity. Second is what is the gradient across this TR? And that is gives you a PA pressures. Here is a gradient across this TR is the gradient is 2.82 and 32 millimeters of mercury. Is that clear? Any questions before we start closing up everything? I know must be tired. Too much of a knowledge in too short a time is. Anybody, any questions, or we can stop over here before I start taking quickly your attendance? And then we separate altogether, not in video recordings. So we'll stop sharing it and quickly take your attendance. Dina, can we stop sharing it? And I'll stop it away.